Good morning, everybody. Welcome to our webinar, Can Digital Technology Help Enforce a Strong Patient Safety Culture? This has been presented in association with Radar Healthcare. It's taken place as part of the Health Service Journal's Patient Safety Congress, which is happening next month on the 20th and the 21st of September in Manchester. My name's Tina White. I'm going to be chairing the session today. My background is within the NHS, and I have 32 years experience from both a clinical perspective, but also in consultancy as well. And I currently work at Wilmington Healthcare. Before we get into any details of the session, there's a few housekeeping notes. We're going to encourage you to ask questions during the session by submitting any comments into the Q&A box next to the live session video. Don't forget to use the Twitter hashtag, which is hashtag HSJPTSafety, and that will help to join the conversation online. And if you need any technical assistance during the call, please use the help desk function that's accessible from the top of the page. And just to let you know, one final thing, that the webinar will be available on demand for a month. So look out for an email next week in case you would like to catch up. So just in terms of the digital strategy, this recognises that keeping our citizens safe is the guiding principle of all staff across health and social care. And people need to be confident that the people who are caring for them have the right up-to-date information about them. So tools such as remote monitoring are keeping people safe in their homes for longer. And if there's anything that the pandemic has highlighted, it's that the importance of prioritising patient safety as a core responsibility across that entire system is evident now more than ever. The pandemic has put immense pressure on healthcare staff and the system, which is making it increasingly difficult to sustain our usual standards of care and patient safety. So now is a critical time for us to lock in lessons and embed positives from the past year. One of these being the acceleration of digital innovation over the last 18 months. I'm going to introduce you to our speakers today. Our panel is made up of three people. Dr. Kelsey Flott, who is the Deputy Director of Patient Safety at NHSX, where she's responsible for leading NHSX's Digital Safety Programme. She's also an Honorary Senior Research Fellow at the Institute of Global Health Innovation and a Module Lead for the MSc in Patient Safety. Kelsey has completed a PhD in Health Policy at Imperial College and an MSc in Comparative Social Policy. And she continues to play an advisory role on various patient safety and academic committees at a local, national and international level. Niamh McKenna is the Chief Information Officer at NHS Resolution and joined in August 2020. NHS Resolution is an arm's length body of the Department of Health and Social Care, which provides expertise to the NHS on resolving concerns and disputes fairly, sharing learning for improvement and preserving resources for patient care. In her capacity as CIO, Niamh is supporting NHS Resolution as they embark on a major programme to enhance the technology capability whilst ensuring continued delivery of services effectively. Molly Kent is our third speaker today and person on the panel, and she is the National Business Development Manager for the NHS and has been with Radar Healthcare for over 2 years. Working across both primary and secondary care, Molly helps organisations to use modern technology to improve patient safety. Prior to Radar Healthcare, Molly has worked for a clinical software organisation where she has led on a number of national digitisation projects to support the NHS to deliver quality and reduce the mounting pressures on the workforce. So I'm now going to ask Kelsey to start the opening statements, and then this will be followed by some panel discussion, and we'll then introduce the questions alongside of that. Kelsey, I'll hand over to you now.
Thank you, Tina. Hello, everyone. Thank you for joining us this morning. Really excited to be talking about this, and especially kind of kicking off with a discussion about digital and safety in advance of the the HSJ Patient Safety Congress. Having been involved in the Congress for a number of years, it's exciting to see the evolution and starting to hear a lot more about digital kind of coming into patient safety, which is exciting to me because that's the role that I play at NHSX. So I'm Deputy Director of Patient Safety at NHSX, as Tina very kindly introduced. But I do have an academic background myself, so have not necessarily come from the technology and innovation background that a lot of my colleagues at NHSX have. So when I got to NHSX, one of the things we started to develop, and this was only in the beginning of this year, was a kind of national direction for digital safety. But what does that mean? That is kind of a national strategy for how we want to do two things: make sure that technology is safe and continues to be safe in the future, but also make sure that we use digital technologies to drive safety. So when we look at some of our biggest safety challenges, are there appropriate digital solutions to meet them, to help them? And we're going to go through some of those examples and some of those today. I think it's important to touch on the kind of need for this. So we already have a national patient safety strategy, which is really helpful and guides us. So why do we need another kind of strategy just for digital? And there are a few reasons for this. I think one Tina's already mentioned around a real acceleration of digital now following the pandemic, but we were also headed in that direction anyway. From a digital perspective, we have had an acceleration. There is a lot more use of online prescribing, use of electronic health records, but also virtual consultations and new care models of delivery, which are new to us, and we need to think about their safety. There's also the perspective of patient safety generally. So we know that there are big patient safety challenges that actually do have digital solutions or could be supported by digital. But we also are learning more and more that this is really important to patients and staff. So I think there have been some publications from the Health Foundation particularly, which show that this is what people are interested in. When we think about the legacy of digital over COVID, we want to know that they're safe. So that's why we kind of need a very clear national direction on this. We need it to focus on those two things: how to make tech safe and continue to make sure it's safe, but also how to use it to drive safety. We need to align this to what we're already doing in patient safety, which is why our strategy will mirror the structure of the National Patient Safety Strategy. By that I mean it will have the 3 I's that we're familiar with in the patient safety world: the insight, involvement, and improvement. But it also have some kind of underlining principles of what digital safety should look like. So we talk a lot about collaboration. Digital safety is everyone's responsibility. It's embedded across different organizations. We talk about openness to make sure we can learn from the intelligence we have around digital safety. We also talk about iterative change. Digital safety is not one thing we're going to achieve and then move on. It's something that changes as technology and the health service evolves. Proportionality, making sure that we have the kind of right risk assessment and approach to digital safety that is proportionate to the technologies we're introducing. And also a major focus on inclusion. We have to get digital safety right for everyone. And actually, when we exclude people, we create more safety risk. So inclusion is another one of our principles. I'll talk a bit more about the strategy over the course of the panel. It's not launched yet. It's launching in September. So look out for that around World Patient Safety Day. But happy to kind of get into some of the questions. And I think the main point to say before I hand over is that the strategy is very nationally focused, and that's actually driven by a lot of frontline consultation and engagement work we did, which really clearly set out that we need to have a national structure and we need to do a few things and make a few national commitments first to enable that change. But on the ground, there will be a difference. And I think the main focus will be around capability and capacity building and knowledge around what digital clinical safety is, how to conduct risk assessments for it, and how to have a a proactive approach to digital safety across the workforce. I'll stop there and hand back to Tina.
Thanks, Kelsey. That's really good. I'm going to hand across to Niamh McKenna now so that she can do her opening statements, and then we'll follow on with Molly. If anyone does have any burning questions at the moment, if you want to put them in the chat box, I'll start collating them and then we can introduce them following the opening statements. Niamh, over to you.
Thank you. Thank you so much, Tina, and it's a pleasure to be here today. So as Tina mentioned, I'm the CIO for NHS Resolution. So some of you may well know NHS Resolution, but we handle claims and disputes on behalf of the NHS. But we have a really important role in safety and learning, and that's a really important function of one of the things that we do, because the primary motivation often for patients bringing a claim or raising a concern with NHS Resolution is because they say they don't want what happened to them to happen to anyone else. And so actually disseminating these learnings has been a really big focus for us, and we've got a number of publications and so on. We have some very good colleagues in the safety and learning function who spend a lot of time developing these guidance and also helping organizations regionally or nationally to provide advice and guidance on how best to implement some of these learnings. So as CIO, when I came in, one of the things that I did was talk to many colleagues about some of the challenges that we're having, and also talk to our board around, things they wanted me to focus on. And you'll see in our strategy, but also in our business plan that, use of our data is absolutely considered key. And one of the things that we've been trying to do is to try and really understand the data that we've got, the insights that we've got, so that we can help bring that learning. And so that's been something that I've been trying to focus on, which is how can we unlock the power of data using digital technology so that we can then bring that information that help people to do that analysis, so that we can then bring some learnings to the system. The other important point is that, a big mission of mine has been to work across the system. We can't work in isolation on any of this. Resolution deals with, as I said, claims. Often, we may be getting to the point of a litigation or whatever. I mean, that's a lag indicator at best. We are at the very end of a process that will start when, a mistake might have happened, something might have gone wrong. How was that handled at the trust? How was the incident recorded and reported? And then at the very end, that might result in a dispute or a claim. So again, it's really important not to look at what we do in isolation, but to really link that back. And that's some of the work that we're trying to do, and Kelsey and I have been talking about. The other thing that we've been trying to do is to bring our unique role to helping people, as Kelsey talked about, this new technologies and the consideration. So we've been working, for example, with MHRA, who've been leading some work around new technologies. Sadly, sometimes these things go wrong. So what are the things we want to think about now up front to help us later on down the line? We'll have seen from some of the very tragic cases around things that have gone wrong, such as the Ockenden report, that actually one of the challenges might be that in 10 years' time, people might not remember things. Do we know what versions of software were used? Do we know what technology was applied and when and how? And as we see this proliferation of technology, and I'm a big fan, so it's not that I'm against it, but we just need to be cognizant of some of the longer term repercussions, and we won't know everything today. So what do we need to do to put in place some of the safeguards that we might want to rely upon in the future? And as I said, that isolation point, it's about that collaboration. And, we hold a small piece of that jigsaw. There is many other pieces being held both at trust level, but also our colleagues in NHS Digital who hold a huge amount of data and can help us. Our colleagues in NHSX who are trying to lead the charge on some of this stuff. So actually, one of the most important things that I think we can all be doing, which is great to have an environment like this to discuss, is how do we all work together to deliver patient safety? Because that is a mission for all of us. I haven't met a single person in the NHS that doesn't want to improve this. So we can all work very collaboratively together. And I think breaking down some of those maybe traditional barriers and silos is something we should all be focusing on. I'll stop there, Tina, and hand back to you.
Fantastic, Niamh. That's really good. And I think that's an area that we can explore a little bit further as we move into this, is that how do we work more collaboratively together, particularly with the changing landscapes that we've got across both primary and secondary community care. How do we start getting some real tangible examples of where that's working well? And we'll come on to that a little bit later on. Molly, can I hand over to you now?
Absolutely. Thank you, Tina, and good morning, everyone. Firstly, just like to say, it's a real pleasure to be on the webinar and also to share this time with Kelsey, Niamh and Tina. Really, really interesting topic and obviously very pertinent now. I think the theme of technology and its role in improving patient safety is a very fascinating one. And it's really the core of the work that we do at Radar Healthcare. Our key priority as a business is about using the best technology to actually make healthcare safer. And of course, obviously, the patient safety strategy is a cornerstone of our work as a company. Our mission really is to empower people to use technology to improve patient safety. And through this, ensuring that not only is it accessible, but it's also easy to use and an enabler for continuous improvement. It should be something that is simple, part of your day-to-day, and almost is an integral part of the culture of that organisation rather than a potential blocker. And then just coming on as well to my own focus for digital's role in embedding a patient safety culture, I vehemently believe that technology should be, as I said, this enabler and making life easier so that people can actually spend more time focusing on where they can deliver the greatest impact. I think there's no denying in saying that the NHS's workforce is incredibly time-starved. It's been a really challenging time for them. There's an element of change fatigue as well, potentially. And actually, the role of technology should be about simplifying the potentially complex and ensuring that people can spend their time in the places that matter the most. So reducing manual overheads, tying together elements in a seamless way, and improving visibility across both an organisation and then outside of those walls across a place as well. Everyone's actually already mentioned that we're in this really interesting time in terms of the role of digital in healthcare, because obviously the pandemic has almost forced us to go remote, and the workforce and patients alike are potentially more digitally savvy than ever before. The use of e-consultation, even small things like the use of QR codes amongst everyone now. However, I still think there are some real key challenges to overcome in this space. And one topic, which is very close to my heart, is around integration. I think from the supplier side, integration ostensibly only refers to the linking of one system to another. And actually, without challenging the status quo and identifying how teams, processes, practices can integrate, this level of system-to-system interoperability can only go so far, really. Under the umbrella term of patient safety, there's a myriad of different processes, teams, people, requirements. And I think it was Niamh who mentioned that actually these cannot be managed in silo. And perhaps historically, some elements have been managed in silo. So when asking the question of how technology can improve patient safety, it's vital to look at the full picture and where technology can be that enabler and neatly tie together a plethora of different components, consider the human factors as well, that's a big element, and also use next generation technology, so AI and machine learning being key examples, to derive real meaning from that data, which can be acted on in a more automated way and, importantly, visible to the right people at the right time as well. So I'll hand back to Tina, but really interested for this session and hearing everyone's questions and comments as well.
Okay, thanks, Molly. You brought up some really good points there. And again, we'll come back to some of that for a little bit more detail, because I think some of the change management side of things, you know, is key to getting some of this technology into place. So just to dig a little bit deeper now, Kelsey, the digital clinical safety strategy, what's this actually going to mean for the people who are on the ground delivering that care, and what kind of support for the clinical teams is going to be available?
Great question, Tina. And I think this is something that take a minute to explain a bit of the background to the strategy and how it works. So the digital clinical safety strategy, which will be published in September, is a joint effort between NHSX, NHS Digital and NHS England and Improvement, and with a lot of input from the MHRA as well. And that's because getting digital clinical safety right on the ground requires working across all of those organisations. We want to make sure that this is very much linked up and embedded within the National Patient Safety Strategy. So working with those patient safety specialists who've already been appointed and started their roles as a result of the National Patient Safety Strategy. We also want it to be very, very firmly embedded within the NHS digital landscape and the digital clinical safety standards that already exist and guide risk management processes around digital technologies already. So that's kind of how we work together as a national team. And what came out of the engagement and consultation around the strategy was a lot of actually what was needed from the front line in order to make digital clinical safety processes easier to follow and more achievable. And the first step really were a lot of national commitments and a lot of national team action. So while the strategy will look quite national in focus, hopefully it has a lot of meaning to people who are working in provider organisations and on the ground as well. So to answer Tina's question, I think the main things that will feel different will first be in that insights section around actually having a place to report information about digital that has contributed to a patient safety event. And this is kind of part of the new Learning from Patient Safety event service that has been replacing the NRLS. Another piece that will feel different is in the more of the involvement side, and that's really probably our biggest push right after the strategy is published, is a new training program for digital clinical safety. Right now we have the clinical risk management training, which really helps people understand how to meet the clinical safety standards if they're manufacturing or deploying a technology. But we want to expand that knowledge. So what you'll see is more opportunities to get digital safety training and expertise, even if you're not going to be at that expert sort of clinical safety officer level. And what it also means in terms of involvement is getting a kind of more, making sure that that information around digital safety, so the standards, the guidelines, the best practice information, is all accessible and kind of targeted at people who are working on the ground. We're doing a lot of work with the blueprinting program to make sure people actually have a what good looks like model to turn to and replicate, because that was one thing that people found that they actually couldn't do at the moment. So those are a few ways that you'll see things changing in a more frontline way, and happy to kind of answer any more direct questions about that. But the last thing I would say is this is a first iteration of the strategy, and much like the National Patient Safety Strategy, it will be updated on probably about an annual basis. So we'll expect some of those things to shift from really nationally focused steps to more local, regional steps as we progress with this.
Grand. And there's a question that's come into the chat box. So what do we think are some of the key challenges that still remain in terms of integrating digital solutions into trusts, and what's being done to address these gaps? Who would like to answer that question?
I mean, I can take one very kind of narrow stab at that question, just building on what we were talking about around training. I think if we think about integrating digital solutions into trusts, I guess one of those first steps is actually doing the background work and some of the clinical safety cases. And one thing that we've found is a bit of a delay or barrier is really having the necessary skills and expertise to undertake some of those safety evaluations and risk management processes to kind of make the next steps on digital integration. But I think one of the points there is integrating is an interesting word, and I know Molly mentioned that a bit as well. But I do think the training and skills to do it is probably one of the big pieces.
I think I absolutely agree. And I think that certainly from a change management perspective, I think there's a huge agenda around what that potentially needs to look like, because I know certainly from experience in places where I've worked that, you know, having the technology is one thing, getting people to actually use it, you know, is a very different ballgame. And that applies to both clinicians and patients alike. How do you think we can address some of this and make it more amenable to staff to be able to take up these new technologies?
Can I jump in on this one? Because it's a
Molly.
wonderful question, and that point about you can use the best technology, but it is only as good as the people using it is just so relevant, because I think the summary here is around engaging people who are going to be using that technology, because we know two things, like I said before: NHS workers, incredibly time-starved. There is possibly an element of change fatigue across some organisations, and change fatigue is a huge blocker, because as soon as you lose the hearts and minds of the people actually required to embed that change, it's really difficult to get anywhere. So from our side, a supplier side, in terms of what we've learned through this experience and what we've taken away, I suppose, I see there being two key points when actually embedding a new piece of technology to ensuring the uptake of that. And the first one is around simplifying the complex. So there's a bit of an analogy to kind of explain that one. If I think about using my phone, if I want to send a text to someone, all I need to do is open my phone, I use Face ID, and I send a text through one click of a button. It's so incredibly simple that it's become an integral part of my day-to-day, and I don't actively think about having to do that. However, if each time my phone updated, there was more and more processes in there, there were more things I had to click through. Actually, as well as the Face ID, I had to put in a passcode and an ID number. Not only would I quickly become disengaged with that process and think, actually, I won't do that, I'll just tell the person face to face, but it also opens up the element for something going wrong. So there are two elements to that, and that's very, very applicable to a lot of situations that we've seen from a supplier side across the NHS, where there are legacy systems that have been bolted on over the years. There are quite clunky integrations, and we're relying on people to actually do incredibly complex processes, which they don't have the time to do. So that's one element, is simplifying the complex and ensuring that the technology you do use as an organisation is so simple and so easy to use. It's an integral part of that person's day-to-day. And then the second one isn't a new concept, and it's just age-old employee engagement. The key really is getting people involved, listening where possible, and implementing their ideas, because the worst thing you can do is push them away and use phrases like the system can't do that, or it's not the way that we do things. People need to be brought into the journey and along the journey right from the off. So a real life example of this is one of the NHS trusts that we work with. When they were looking at technology and making the decision to use radar, they brought people in right at the beginning from a cross-section of roles, including frontline workers, including people who would be managing that project. So not only were people empowered to work with that project and make decisions, they were also fully engaged as they moved forward as well. And not only then are you just implementing a piece of software, but you're also opening up the opportunity for real change. And it allows you to actually engage people across different cross-sections of the organisation in a really meaningful way.
I'll just jump in on a slightly more tech angle. So absolutely 100% agree with what Molly's been saying there. But the other thing that I would say about that question in terms of integrating digital solutions is I think people always underestimate how difficult it is to integrate these digital solutions. You know, with the best will in the world, every single organisation out there in the NHS, and quite frankly in the private sector as well, has got a real mishmash of, shall we say, legacy, older technologies and newer technologies. And actually, despite the sales patter, it is not that easy to just bolt something on the
Absolutely.
side. And it's quite challenging. And people always underestimate. They go, oh, yes, but this thing can just sit over here. It's really easy to use. Well, that's great. But actually, if we've got a legacy system that works in one way, produces data in one way, can only understand inputs and outputs in a certain way, and that's a different thing. You've got to find, technology to orchestrate between the two. That's actually not that easy to put in. So I think we underestimate the human challenge, and I think we underestimate the technology challenge. And it's just all a bit harder, and that's not very palatable sometimes to people. They just go, but the technology's out there. Yes, it is, but it isn't quite as simple as that.
Mm-hmm. And what can we do to try and support staff on the ground with that technology then? How can we make it more doable for them? Because when they are so entrenched in their day jobs, taking on a new type of technology can sometimes seem quite a big challenge, so what kind of support can we offer that can make this a much more bite-sized kind of task to take on board?
Well, I'll just give one small example, which maybe might help. So we've just implementing a search capability across our document set. So really important piece of work where we're trying to help our people focused on safety and learning access the data that will help them learn. And at the moment, we've got 12 million documents. You'd have to open each one up and read it. It's a very insurmountable task. Where we've gone with our document search is to make it like Google. So at the end of the day, to Molly's point, people know and are familiar with existing technologies out there, with technologies on our smartphones, technologies on our desktops. So we could have gone a bit mad on the old service design and come up with something whizzy, but actually we've just gone super simple. Yeah. So again, I think there is that combination: be responsive to user needs, but also try and align back to the simple and make it super simple to use and very familiar to use. And sometimes that might mean compromising a little bit on some of the fancy service design elements. But actually, if it looks a bit like something you already know, then that familiarity can help you. And then you can increment change from there, because the good thing about these new digital technologies is they're easier to build on and release on.
Yeah, absolutely. Would Molly or Kelsey want to come in on that point as well?
Happy to. Sorry, Molly, go ahead.
Oh, thanks, Kelsey. Just echoing Niamh's point as well about the simplicity. I think if you are relying on a input from anyone across a cross-section of people, making it as simple as something that would be used in their day-to-day anyway. So Google, great example, a phone. If it can be as simple as that, then it's more likely that you'll get staff engagement. And also when doing that design element, ensuring that the people who are going to be using the system are actually involved from the off, so that they can input and say, actually, and using an incident form as an example, it would be simpler if we could do it like this, or I want to see this. And as much as possible, looking at a cross-section of people and integrating those ideas into a really simple, really accessible solution, and also ensuring that it can be something that's used on the move as well. Because I think often, like Niamh said, more legacy solutions, they're quite complex, and you might have to be at a certain location to actually use that particular piece of software. If you can use something that doesn't disrupt your work, and it's as simple as sending a text or compiling an email or whatever it might be, you've got a greater chance of actually getting across the board staff engagement.
I totally agree. Kelsey, were you wanting to add to that?
The only thing I was going to add is very much agree. And I think to enable some of the ability to do that, to make sure that we're building and investing in technologies that are simple and kind of user-centered, there's also a part of making sure that getting the tech right isn't the sort of bolt-on job of a already busy kind of clinician or manager. I think there's a real kind of step we have taken in some areas, but not necessarily all, to make sure that actually kind of technology, IT, digital is fully resourced and has an expert level of kind of knowledge in-house in organizations, so that someone who is technically expert in this can make sure that the technologies that are used day to day on the ground are meeting those staff needs, and people don't need to kind of reskill just to be able to work with the technologies that they're given.
Yeah, I think that's a really good point. So we touched a little earlier on how we need to work more collaboratively together. Are there any examples out there that where we've demonstrated the use of technology in enabling us to be able to do this more effectively?
Sure, I'm happy to talk to a couple. So we've got the example I just mentioned, which is an example of how just giving people quicker access to data and information will then help with patient safety, which is around surfacing up information that might have taken weeks or months to get at. Due to the nature of how it's held in the legacy systems, just surfacing that much more quickly so that people then can get on with the business that they want to do, which is doing the analysis to be able to, improve patient safety and give learnings back out to clinicians. The other thing that we've also done is to start exploring, which we've been doing with NHSX, actually, who've given us a lot of support in this area, exploring what potential relationships there might be between claims and other data that's out there. So we did a piece of work. It was just a proof of concept, but just started to explore and say, well, look, there's lots of data out there in the system around things like staff sickness levels, bed occupancy, yada, 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 lots of information that NHS Digital collect. Is there any relationship or any value for us to be looking at that data alongside our claims data? And so again, that was another great example. It was an early stage proof of concept. The idea was to start the process rather than there's no amazing conclusions we can draw yet, but to see actually it's possible to look at that data. It's possible to use that in conjunction with our data. And then out the back of that, we've been then having discussions with Kelsey about what can we do next to start bringing, the patient safety element in. And, I'd love to be able to start connecting the dots, as I said, across the system. It's about that, not doing it in isolation. I can go away and noodle through my own data, but actually, if the real value is how can I support a different part of the system looking at incident data, or if I can support them, maybe we'll get better outcomes overall.
That's really interesting as well, Niamh, because it's something that we do as a company, and it's something that a project that's really interesting to us is around looking how you can connect the dots and actually acting as that golden thread of patient safety across many different elements. So seeing it's something that we're doing with one of the NHS trusts we work with, is bringing in third-party data as well as existing data and radar to look at how the number of mandatory training records that aren't compliant on a particular ward versus bank staff on that ward, the number of incidents, the number of complaints and type of complaints that are coming in, and how this affects, and also bringing in human factors, the interplay of those different points, and being able to triangulate and draw conclusions from those in a more automated way, so that you can have a clear ward-to-board picture of these are my emerging risks, this is what's going really well, and I've got a picture of best practice which I can share now. And then you can actually you're paving the way for a very well-oiled machine for continuous improvement.
Absolutely. I think it seems to be the kind of golden kind of idea in safety around using our data sets in a more triangulated way. And we have data sets that are specifically safety that we can look at in kind of in conjunction with each other, but to Molly's point and Niamh's point, really to make sure we're looking at diverse sets of information to draw safety conclusions. One thing that we and I'm stealing from my colleagues at Imperial where I used to work, but one thing we did as an example of this back there, and Niamh and I have talked about this, is applying sort of kind of natural language processing algorithms and using some of our machine learning capability to look at lots of the patient feedback we were getting as an organization. So in any given NHS organization, you might get, say, for instance, on the friends and family test, which goes to pretty much every patient who's coming through the hospital, you might get up to 20,000 sort of free text responses coming in every month. And these can be long or they can be short, they can have really important details in them, but there's not the human capacity necessarily to really meaningfully derive information from those and theme them. So we're able to apply a natural language processing algorithm to start to learn from those and actually get a picture of what our patients are telling us in a much more quick and easy way, which enabled those people to do their job, feed that into kind of safety discussions, if it was safety relevant or quality or whatever, which is just one use of how the kind of technology can help people do their jobs and communicate the data that they're getting in.
Helps if I take the microphone off mute. I think that's some really good points. And I think, what's coming across loud and clear is how important this is for patients. I think as well, some of it is understanding from a staff perspective, that they have the right skills and experience and training to be able to deal with some of the technology. And moving forward, we need to make that, I think, easier for them to access, so that it's a lot more readily available. When we talk about some of the sort of preempting some of the safety risks, it was one of the points that you picked up, Molly, earlier on. What kinds of examples have we got where digital solutions can help to preempt some of those risks, where we can draw on them so that it prevents us from getting to that point where they cause harm?
No, absolutely. So it's a great question, and it's about moving from a reactive approach to a more proactive, anticipatory model. And of course, technology can be the cornerstone for that. One example which always comes to mind for me is some work that we've done with the Ministry of Health and Prevention across the UAE. Not NHS, but the setup obviously was relatively similar in that they've got 17 hospitals, 72 primary healthcare centres, so a very large estate and a lot of activity. What they've been able to do using radar is actually use analytics and AI to do excellence and variation reporting across the estate. So it allows people to input information easily, on a phone, as we discussed earlier, the easy use of technology. And then this information feeds up into advanced analytics, which gives people the oversight and automatically flags. This is something that's going really well. Here is some outstanding practice, which you can share across the organisation. Here is an emerging risk. And then also using predictive analytics to say, based on this aggregated data set, there is a possibility that this could happen over the next 2 months. Would you like to put some controls in place? So using a really integrated in every sense data set, as well as tools such as AI, machine learning, predictive analytics, gives people the opportunity to not only have a clear visibility of existing activity, but also understand the potential of what could happen and how you can mitigate that at this point. And then obviously when you get to that later down the line point, you can compare that data set, what was predicted, what actually happened, how can we, and again, I come back to continuous improvement because it's all about that.
Yeah, I would also add, Tina, in there, I think that point around the visibility that Molly raised is so important. So, we support, and I'm sure others are aware of, the Getting It Right First Time initiative, GIRFT. And some of that is just about letting people know about those variations. People, are heads down doing their jobs, and they may not actually realize that there's a variation here, or that actually there are this trust over here is able to achieve better outcomes. And so some of that is just about surfacing the visibility, which is, in a weird way, not the glamorous end of digital technology. This isn't about, putting some whizzy robots in or fancy systems. It's just about surfacing the right information to people at the right time, in the right way, so that they can then take an action. I had a conversation earlier this week with one of the CCIOs who's hosting a forum of CCIOs, and we were talking about just that. He was going, I just don't know. I don't know how much information is money's been spent on claims. And I said, well, funny that, because we actually send that out to the trusts. And he just wasn't aware that information was being provided. So I think there's a lot around visibility and learning, and again, just keeping it simple, as we've been saying, rather than over complex sets of information, but just who needs to know and what do they need to know.
Yeah. And I think certainly from a clinical perspective, the people at ground level, understanding where them claims are being made and what has been the key things that have underpinned those claims, will obviously then encourage learning from that, for future. Kelsey, were you going to come in there?
Well, just to come in with actually an example of tech that could be used preventatively and proactively. And it's one thing that we've really seen coming out of the pandemic is the kind of increased use of remote monitoring technologies. And I think if we start to think about safety in the kind of proactive and preventative sense, we're thinking, okay, well, how do we avoid a situation where harm might occur? And the main thing there is making sure we avoid deterioration. And it's really interesting to look at what's happening in remote monitoring, where not only are people feeling like they can actually receive the information they need to about their own condition and act in any kind of signal of deterioration, but actually there's a real knowledge sharing there where a patient or the person caring for that patient has access to the same information that they might have if they were in a health service or with a doctor. So it's not only kind of preventing deterioration, it's also helping balance out who has access to what patient information. And I think remote monitoring will be a one to watch in terms of how it kind of spreads across the system and enters new pathways of care.
Yeah, I absolutely agree. And I think, the pandemic was a fantastic opportunity for us to get some of these things into place, because I know certainly in my experience previously, when we've tried to do things virtually in the past, sometimes it hasn't always gone too well. And a lot of that has been from both a clinician and a patient perspective, for different reasons. But I think the pandemic kind of pushed us into letting go of some of those comfort blankets and really kind of trying to develop some innovative working, I think. When we talk about some of the areas of innovation around remote working or any kind of innovations in terms of digital technology, have we got any examples of where, that element of inclusion, where we've included maybe from a patient perspective, the kind of things that they might want to see, or from a staff perspective, what kind of examples have we got?
So I can answer briefly from a research perspective as well. So this is kind of going back to what's happening in the research community coming out of the pandemic, is if we're starting to see remote consultation and remote monitoring really become the norm. So I think in the pandemic, it was the rates of virtual consultation absolutely skyrocketed from what they used to be. And we're seeing that start to continue. So some of the research that's started is actually looking to see what different patient groups and different staff groups need out of remote consultation and what some of the risks might be for other groups. We also know that there's a kind of digital and digital exclusion and a digital inclusion narrative that we have to kind of get right. And while digital is opening up access to consultations for some groups of people and making that much easier than it used to be, we also know that it's not necessarily working for some. So I think what the research community and the scientific community is going to help get right is, who does this technology work for best, and how do we make sure that it's not normalized for those that it doesn't work for? So I think that's one example of where we're starting to see the influence of different patient needs and different staff needs kind of influencing service design and pathway design. Oh, Tina, I think you're on mute.
You'd think after all this time, wouldn't you? Molly or Niamh, is there any other comments you would want to feed into that before we move on?
I think just from our side as well, with supplier engagement, or from the supplier side, it comes back to that simplicity piece as well. And also some of the work that we've been doing around friends and family feedback, which was mentioned before, and actually enabling people to have access to being able to give feedback on their time, feedback from both a patient and also a family member perspective, and having that fed into a system which enables them to sort of be involved in that and get feedback as well, and having a more digital approach to